It gives me great pleasure to introduce Dr. Nicole Saux today. Dr. Saux is certified by the Royal College of Physicians and Surgeons of Canada in internal medicine, infectious diseases, and anatomical pathology. She's a full professor at the University of Ottawa, and she does both pediatric and adult ID and has done this for the past quarter century, which is a very long time. She likes all aspects of clinical medicine, but her most cherished accomplishment is the founding of the OASIS Childcare Center on the Health Sciences Complex. I'd like to add that just like with the OASIS Childcare Center, when Dr. Saux sees a problem, she tackles it with full force. And she really has developed this antibiotic stewardship program at CHEO from scratch and turned it into a nationally and internationally recognized program and has made huge strides in the development of the pediatric ASP field. So please join me in welcoming Dr. Saux to this interestingly themed title, Antibiotic Stewardship, Safety, Durations, and Collaborations. All aboard.
Thanks, Dr. Huey. That's a very kind introduction. So I'll get started by saying that in the past, I'd used the symbolism of a cruise ship, but with the stark reality of cruise ships as infectious disease vectors and the fact that all these people are very passive, I thought the idea of canoes actually is much more Canadian and that everybody is working hard together to get to their destination. And it's more in line with what we do in stewardship. So just as a brief reminder, stewardship is unique in terms of drugs because it does have an individual and a societal aspect to it. And it was first used in 1997 and really takes its root from being a good steward for the church. So it's really, stewardship's a coherent set of actions and promotes using antimicrobials responsibly. So it's not really about conserving, but it's about optimizing therapy for individuals and also society. So usually this slide goes at the end, but I really wanted to acknowledge all the individuals who have been keen participants over the years in stewardship, and particularly the huge amount of work that the Department of Pharmacy has provided. I do stewardship with the Division of Pediatrics, and you'll see these people that have been and continue to be on the Antimicrobial Stewardship Committee, the Surgery Division, Critical Care Units, Dr. Al-Karashi from Emergency Department, and particularly the CHEO RI, Jen, Nick, and Anne that have put together a lot of our data, the ID division, Lindy and Nisha that help in the stewardship rounds, and all the others that actually really support very heartily the stewardship program. And the reason there's a green box around these two particular individuals, Maria Latwinska and Matthew Nelson, is that they are part of CHEO, and they will present later on when we present the dashboard for antimicrobial stewardship. So welcome, Maria and Matthew. So the objectives of this talk are really threefold: to acquaint prescribers with the concept of safety issues with antimicrobials. Secondly, to review current concepts for durations of antimicrobials, which is actually changing. And then the last thing we'll do is to describe metrics for antimicrobial use that are and will be used at CHEO. So I'm not going to say anything more about this, but except to say that we are working on a sleeker new look for the Spectrum app. And you'll see that coming down the pike probably early in the summer or late in June. And we'll have updated modifications for durations, clinical diagnostic considerations, and a new and improved adverse events section. So the first thing I have to say is that the slide illustrates that we're all aware of our love affair with antibiotics. However, it's really important to appreciate and balance the known side effects of drugs against the decision not only to prescribe, but extend durations of antibiotics. So this data, this is outpatient emergency department visits. As you can see from this slide, the antibiotics are responsible for between 30 and 50% of children presenting to emergency departments with adverse drug events. So it's not an unnegligible amount. And as one of my colleagues have said, the likelihood of a patient developing an adverse event is inversely proportional to their actual need for the drug. So we always need to keep this in mind when we're prescribing these antimicrobials. In hospitals, although we have adverse event reporting systems, because they're not life-threatening, many of them don't get reported. However, this is a study from Japan where they had people actively report adverse events, and about 22% of adverse drug events in the hospital were antibiotic related. Surprisingly, though, 50% of these were due to beta-lactams, which is really traditionally considered overall one of the safest classes of antimicrobials. So you can see most of them were dermatologic, and then hepatitis and so forth. So in the next few slides, I'm going to briefly highlight a few of the safety issues that were really are new and that we don't often think about when we prescribe antimicrobials. So the first one here is about vancomycin. We all know that vancomycin, and we think of nephrotoxicity. However, this study was conducted in 62 NICUs in Germany, and they looked at infants who failed the post-discharge hearing tests. They found that vancomycin cumulative exposure, so greater than 50 milligrams per kilogram, proved to be independently associated with a pathological hearing test at discharge. And this suggests that one has to be mindful of the cumulative exposure, not just the individual trough levels of vancomycin. This one's one of my favorites because we don't often use fluoroquinolones in children, but I think people need to know that there are warnings actually on the Health Canada website about serious adverse events of fluoroquinolones, and the FDA has produced 8 black box warnings for the fluoroquinolones, and I'll just point out a few of them that don't affect really children very often, but aortic dissection, an aneurysm, 1 in 10,000, tendinopathy can occur in adolescents, but mainly in people who are older, QTC prolongation, of course, the very well-known C. diff colitis, and then colonization with gram-negatives resistant fluoroquinolones. So I always tell people, if you can recite all of these, then go ahead, you can prescribe fluoroquinolones. One of the things that we often see in adults, but because in CHEO we don't usually use the combination of piperacillin and vancomycin, people and adults are well aware of the combination of these two antimicrobials, and it increases the risk of AKI by 3 to 9 times over the use of vancomycin alone. So there have been about 10 studies from children's hospitals, and some of them have been founded, some of them not. So there was a systematic review of these studies, which found basically the same relative risk of AKI in children as in adults. And the median time is usually 3 to 7 days. No one really knows why this happens, but kidney function usually recovers once these antimicrobials are withdrawn. This is about metronidazole that's often used to treat intra-abdominal infections and necrotizing enterocolitis in neonates. And because metronidazole is superb at penetrating the central nervous system, it certainly can cause CNS side effects, delirium, confusion, and can also, you can see white matter lesions, as you can see by these arrows, and peripheral neuropathy. Most of the time it's with greater than 4 weeks use, but there certainly are case reports with shorter durations of metronidazole causing central nervous system and peripheral neuropathies. Amoxiclav is actually one of the new kids on the block, and now that we have IV amoxiclav, I expect that people will use it a little bit more. Not only does it carry a high risk of diarrhea of about 9%, but you can also develop an allergy to the clavulanate component. Most people aren't aware, though, of its hepatotoxicity, and in this nice review of hepatotoxic drugs from J. Hufnagel, amoxicillin clavulanic acid topped the list in terms, even higher than isoniazid, as a cause of cholestatic or mixed hepatitis. And as you can also see, the top 9 are all antimicrobials. Cefixime and ceftriaxone certainly are have all the qualities of easy giving. They're once a day dosage, they're broad spectrum. So really, if it had a Facebook page, this would receive a lot of likes, I think. But people sometimes aren't aware of this silent epidemic of major disturbances in the microbiome because of its broad spectrum activity. And the reason is probably the high concentration in the bile, and obviously can lead to gut colonization with ESBL organisms, VRE, and a high risk of C. diff. And then there was a a nice study actually published in PIDJ that looked at those people who had third generation cephalosporins. And if you use them longer than 48 hours, there was an increased risk of harboring AMP-C ESBL organisms, which basically reminds us that we really have to do reviews of antimicrobials before the 48-hour mark. And then just the last one is I'd be remiss in not reminding people of TMPSMX, which can cause serious and life-threatening issues, including Stevens-Johnson syndrome, AGEP, and drug fever in general, as well as renal dysfunction. So with respect to the potential toxicity and development of resistance, the WHO has actually wanted to incorporate these aspects in creating antibiotic groups that are separated really based on not only the access to antimicrobials, but their potential for developing toxicity and resistance. So they've divided these into three groups: the access group, the watch group, and the reserve group. And the access group are the ones that are affordable, quality assured, and should be accessible to everybody basically on the planet. The watch ones are recommended only for specific or limited indications, and the reserve ones are really those that should be used as a last resort when all other antimicrobials have failed. And if you look at the website, here's the list. So the core access groups are ones that we use very, very commonly. And there's also a group that mainly belong to the watch, but this group, you can see there also should be accessible to countries and places because they're very indispensable to treat meningitis and also pseudomonal infections. So the watch group are those mainly the third generation cephalosporins, the anti-pseudomonal penicillins, quinolones, and actually macrolides and glycopeptides, vancomycin. Then the reserve ones are things that we don't often use at CHEO, but we certainly have if required. So you say, I usually stick to core access ones, so I don't see a problem with the prescribing. And that's good. And children's guts and their respiratory tracts certainly thank you for that. But the last thing I'm going to discuss in terms of possibly side effects are basically it's the increasing incidence of asthma that's been seen around the world. And although we wonder whether it's the germ theory that's promoting this, people have also wondered whether the frequent prescription or the prolonged prescription of antimicrobials has done some damage to the respiratory microbiome that alters the immune responses. So I wanted to share with you, and there's been many studies, at least about 15, that have promoted the fact that antimicrobials may have something to do with it. But there was a nice study just recently published in Clinical Infectious Diseases that was a prospective study in Tennessee of 150,000 children. And what they did is they tracked antimicrobials in the first year of life only, and then they followed these children and looked to see whether they had been diagnosed with asthma between 4.5 and 6 years of age. And what you'll see is, almost 80% of them at least had one antimicrobial fill in the first year of life. And most of these obviously were narrow spectrum. And here's the results. Not unsurprisingly, as the number of antimicrobial prescriptions during infancy increased, so did their risk of developing asthma. And compared to children with no antibiotics, there was a twofold increase in the odds of developing asthma. And it really didn't make a difference whether this was broad spectrum or not. And then when they looked at whether the kids had had bronchiolitis or not, the increased risk associated with the number of antimicrobial prescriptions was also present, regardless of whether the children had been seen for bronchiolitis and regardless of the level of care they had, which also supports this association. So we'll move on to the next sort of objective. And as you know, these are linked together because duration obviously and the frequency obviously would probably increase the amount of adverse events people might experience. So the history of durations. You know, in the 1940s, we gave antibiotics so that people could survive and to cure. And so really the durations are very, very short. 1 to 4 days of penicillin for pneumonia is what people usually got. And then over time, these courses got extended. And the idea was we wanted to prevent relapses and eliminate the bacteria, which we all know this is actually false logic because we can't really eliminate the bacteria. And the bottom line is actually we're waking up to the fact that we probably need to use shorter durations of antimicrobials. And you'll see if you ask any ID physician or multiple ID physicians, most people will have a different idea of duration. And this was, I just want to highlight this one study done in Ontario actually, that said that later career physicians usually prescribe longer courses of antimicrobials. This is outpatient data, but they described later career physicians as greater than 11 years in practice. So I think we all have to look at our durations and see whether we can actually do better. And hopefully we're not going to be tagged as late career or early career on that basis. So this is the long list, and it's a bit sarcastic, of infections for which durations are really mostly known. So you can see, you know, meningitis, otitis, endocarditis. It's very, very short in actual fact. And, you know, the vast majority of things we treat, you know, sepsis, UTIs, pneumonias, sinusitis, cellulitis, most people, there's no real established duration, partly because we actually didn't do really good studies at the very beginning of this odyssey of antimicrobials. So this is a table that I lifted from Brad Spellberg's article about durations. And he actually did a small review. And if you can see here that even though these short courses were actually almost about half of what the long course antibiotics were, there was actually equivalence in the clinical cure rate, suggesting that we really ought to reconsider the prolonged durations that we're used to giving for infections. If we look at pediatric community acquired pneumonia, which is a quagmire in and of itself, because there's no objective correlative cure or even diagnosis, there's many different guidelines. The CPS says 7 to 10 days, and there's no allowance for severity. The AAP has 7 to 14 days. That's been archived probably because of the 14 days. And the NICE guidelines in the UK say 5 days if mild to moderate. They shift to amoxicillin clavulanic acid. They also say 5 days, and they get if it's severe, and they give criteria. So really shortening very significantly the amount of antimicrobial duration. So what I want to share with you is more of the studies in the adults. And so this is a study in JAMA. Now there's several other studies that have looked at this, but I'm presenting sort of the bigger one for which the ATS guidelines were made. And this was a study done in Spain. And what they did was they randomized people, and these are hospitalized patients with pneumonia, and they randomized people to 5 days, or, you know, the intervention group was, the control group was really just whatever the admitting physician gave them. And it ended up being a median of 10 days. And they followed people up to 30 days, but they looked at the clinical success at 10 days. And the clinical success, you know, is really between, you know, 50 and 60%. And there's really no difference at 10 days between at 10 days between the 5 days people and the 10-day group. And then they looked at their clinical success at 30 days, and you can see that this is very, very high for the pneumonia severity index that were less severe ones, and even for the more severe ones, there was greater than 90% success rate, even for the 5-day group, suggesting again that the durations could be shortened. So the American Thoracic Society and IDSA recommendations for adults have stated in their guidelines that was put out in 2019 that you could use 5 days if the patients had a resolution of vital sign abnormalities. They were able to eat and obviously had normal mentation. The only exception would be if you had MRSA or Pseudomonas, which they recommend probably a 7-day duration. So I think it's really important to note in these trials that people continued to improve even 2 weeks after antimicrobials were discontinued, which suggests that with these antimicrobials, we probably reduce bacterial load, and people's immune systems, if they are intact, probably mops up the remainder and leads to actually going back to baseline within 2 weeks. So this trial is actually unique because it was done at McMaster and also at CHEO. And I've highlighted Des Pernica, who works at Mac, but he used to be an ID fellow here. Stuart Harmon from RED. Dale Daglish is also an RN from RED, and Bob Slinger, who was part of our ID department. So this study randomized patients who presented to the emergency department and were discharged between 5 to 5 days or 10 days of amoxicillin. And as you can see, about 60% of them, or 75% of them, sorry, had pneumonia diagnosed by a radiologist. And the CRPs were a bit modest, but that's okay because they were outpatients. And really what's important to remember is to take home is that many of these had viral infections, but really a virus, regardless of whether you establish it or not, it really doesn't tell you whether you have a bacterial pneumonia. And even in the subgroup that had a consolidation on the chest radiograph at 14 days, there was about 90% cure rate. And then when you looked at it at 21 days, over 94% cure rate, suggesting again that 5 days is sufficient, at least in this group. And the star here reminds me to tell you that there is an NIH community acquired pneumonia trial in children that's finished, and they haven't actually released all the results, which will use this desirability of outcome rating and response adjusted for duration of antibiotic risk to really capture the total experience during a trial. So they'll look at benefits and the collateral damage that these antimicrobials can have. And it's a bit like, I think the easiest way to look at it is if you went out to eat at an expensive restaurant and you had a really great time, but you paid $300. So your Visa card took a big hit. And on the way home, you say, gosh, could I have gone to a less expensive place, still had the same amount of happiness, and had less collateral damage to my Visa card? So that's sort of the whole gamut of what they're trying to look at here, a practical example. If you look at urinary tract infections, this is again very much of a quagmire, and the guidelines, as you can see here, are kind of all over the map. And this study is actually the only study that looked at total duration in children. This is a study from Johns Hopkins where they recommended actually only 7 days in their treatment guidelines for pyelonephritis. And they randomized almost 800 patients, not randomized, this is a retrospective study, 6 to 9 days versus 10 days. But they also included in this children with abnormal urinary tracts. They had good criteria for a urinary tract infection. And I'm telling you, the bottom line here is that they found that there was no difference actually between the short course and the prolonged course of therapy. However, the median days for the short course was 8, which is above what they recommended in their guidelines. And the long course median days of therapy was actually 11. But I think the take-home message on this is that patients with urologic abnormalities certainly had a huge amount of failure rate that would be pretty well unacceptable here, with a 23% in the short course and even 16% in the prolonged course. So I think the error in this study was that they mixed up people with underlying genital urinary abnormalities with people who had normal urinary tracts. So you have to be very careful. Here's some adult studies on bacteremia, actually systematic reviews. Traditionally, we were told, at least when I did my training in the first probably 15 years or 20 years maybe, I always was reluctant to go less than 14 days for bacteremia. And this is 2 systematic reviews, and I've just lifted some of the tables from there. This one was published in 2011, and they looked retrospectively, systematic review at individuals having 5 to 7 days versus 7 to 21 days. And you can see the outcome for microbiological cure was the same for both groups. And then another one in 2019 by TennCare used less than 10 days and greater than 10 days. And you can see there was no difference in clinical cure. So again, suggesting that maybe 10 days is the magic number for bacteremia. And then the last study I'll tell you about is a study published in JAMA in 2020, where they looked at bacteremia, again, uncomplicated gram-negative bacteremia, about 500 people, and they individualized it and gave physicians the option of using CRP or randomizing people to 7 days and 14 days. And there was a lot of protocol violations actually in the 7-day group, but nevertheless, you can see there was no statistical difference in the failure rate between the 3 groups. And it ended up that the median number of days, if you had CRP guided therapy, was 9 days. And even in the 7-day group, the median number of days was 9 days. And although this looks like 14 days here, the median was 16 days in this group. Again, no clinical difference in the 9 days versus the 14-day group. So just the caveats for duration is that if you have an inability to achieve source control, you may want to go longer, as these serves as reservoirs for persistent infection. Immunocompromised hosts as well, you may not, there's not too much data, but you may consider going longer. And then the type of bacteria, as you know, we have a few bad actors, MRSA, Pseudomonas, Stenotrophomonas, and other resistant pathogens where we don't have a lot of, the antibiotics often aren't the greatest. But just then I think it's really important to know that in many circumstances, this is low-hanging fruit, the duration. And this is a study from South Africa where they actually they had 47 hospitals, a huge number of hospitals, but they didn't have 47 ID physicians that were directing their stewardship program. All the 3 ID physicians did was to give people guidelines, these pharmacists guidelines about treatment durations, clinical conditions for which you had 7 days or 14 days, and also an ability to act if there was 2 antimicrobials with duplicate spectra. They excluded endocarditis and osteo and anybody with prosthetics. And what they did, these pharmacists, was basically just call up physicians if they noticed this, and they just intervened on durations, and you can see the decrease in antimicrobial use, suggesting that durations is in fact a very good option if we really want to make a big dent in antimicrobial use. So just to let people know that there is an AMI, which is the Canadian Association of Medical Microbiology and Infectious Diseases. And Jennifer Grant and I did this practice point on duration of antibiotics, and we've covered a lot of these common infections. And just because it's a pediatric audience, we weren't rogue about this. The Canadian Pediatric Society did review it and actually endorse it. So you may want to check that out at one point. So the last part of the talk will be about metrics. And I'm a fan of this guy, this accountant called Peter Drucker, and he said, what's measured improves. So I just added in here, what's measured and reported to stakeholders improves. So we struggled for a long time with metrics at our hospital, only because it was very difficult to do basically chart reviews on people using antibiotics. So we also wanted to compare ourselves to other pediatric hospitals, but they didn't have the same IS systems. So we landed on these point prevalence surveys to compare ourselves to other hospitals. And remember when I told you that there was access group antimicrobials and watch group antimicrobials? Well, we did this. This study actually represents about 2,000 patient days on antimicrobials. And we did this in 2 days. So all the 15 pediatric centers did point prevalence surveys, and then we numbered these hospitals 1 to 15. And as you can see, we're number 4, and we're the hospital that has the highest amount or proportion, I would say, of our antibiotics are access antimicrobials. So this is the number of patients, and this is the percentage among those who received antimicrobials who received access. So that's a good thing. And then if we look at the watch antimicrobials, it's actually the opposite. That CHEO is actually on the bottom, and that's also a good thing. And this is actually the 95th% confidence intervals and the 98.5% confidence intervals. And these are actually funnel plots. So that was a good news for CHEO. And then because we don't really have a lot of guidelines, this was just to see whether there was a practice point concordant therapy. And you can see this is based on 152 cases during those point prevalence surveys of community-acquired pneumonia. And here's a CHEO. Most of us use amoxicillin, or ampicillin or penicillins, with a few receiving azithro. And you can see a lot of the other sites are all over the map in terms of different antimicrobials. This site is a very small site who only contributed about 4 cases. But in fact, we were very happy to see this. So we really wanted a dashboard, and we really wanted this to be the day. It's a kind of gold standard, is the days of therapy normalized per 1,000 patient days. And it takes into account the duration of antimicrobials if they're stopped in the hospital. Obviously, we can't do the outpatient, although that's one of our plans. Our ultimate goal really was to create a dashboard so that units, services could see their own antibiotic use over time, overall, and by antimicrobial class, because it's no use if you decrease your 3rd generation cephalosporin use, but increase your use of pip/tazo, for example. And we also wanted to see it later by diagnostic code. So I struggled with this a long time, and it seemed impossible until I met these 2 very, very bright people, Maria Litwinska, who's a CHEO business systems analyst, and Matthew Nelson, who's a CHEO quality improvement advisor. So what I'm going to do is turn this over now to Maria and then Matthew, and they will take over and explain the dashboard to you. So I'm going to stop sharing now.
Oh no!
Oh no! So you want me to? Oh, that's right.
Pull it.
Oh right.
Pull the last slide.
Yeah. Sorry. Here. Go ahead. I'm just going to put it on yours. Okay. Go ahead.
There you go. Yeah. So this is a very quick overview how I pull data from EPIC, because EPIC is our source of data. So first, I look for the antibiotics in Willow, which is the pharmacy module, and looking for those classes or subclasses that we're gonna then expose on the dashboard. And then I look at MARM, medication administration record, and this will indicate whether patient was on antibiotic, when, and number of days, and that defines my days of treatment or antibiotic days of treatment. And then to that data, we add also the unit and attending service. So we look at the attending service when the patient was admitted as inpatient, and the first unit, we have 2 different sets of data. We have for emergency and for inpatient. And then for emergency, we look at the days in emergency, and for inpatient, days as inpatient. And this information comes from inpatient and ASAP, which is the emergency module. And the 2 points are census data and discharge date. So census data or census date is the date if patient is an event in EPIC that when patient stays overnight. So we know that was a day, and then discharge date. We need to also look at the encounters, because we add discharge diagnosis. So discharge diagnosis kind of dictates that we need to look at encounters or visits on the visit level. So that means if emergency has, let's say, 2 visits for patient, and during these 2 visits, 1 class of antibiotics with different routes was administered, would have 2 days, not 1 day. So for the discharge date, discharge diagnosis, we still look into EPIC. However, in EPIC, we may not have a marked discharge diagnosis on the encounter. So If we don't have it, I look maybe to compensate with the admission diagnosis or clinical impression, first clinical impression. And of course, there's a data delay because when we run these scripts or these queries, the patients may still be in the hospital. So in the future, we think that we're going to look with the coded diagnosis, discharge diagnosis would be more comprehensive, and this data would come from WinRx database. It's a different database that coders are using at CHEO. We pull the data from 2018, so we get very big sets of records, and it's growing. I think we're up to 100,000 rows right now, and Matthew will show you the how it looks like in the dashboard, but it's not sustainable. We want to really port it to the better tool instead of pulling manually or running manually scripts and then putting manually into Excel dashboard. So with that, I'm gonna pass it to Matt for the demo.
Sorry, I'm just working on figuring out which screen I have this thing on. There we go, this one. And I apologize for looking like I'm in witness protection. I'm not, it's just a nice day outside and I have this bright sun behind me and it makes my face all black. So anyways, can you see this? I just want to make sure that I've shared the right screen. It's an ugly table from Excel. Okay, so this is the stuff that Maria was talking about pulling. So this is the input data, which has our unit and MRN and CSN. So this is so we can link it at the end. The service, some gender, the date that the administrator or the subclass was administered, admit and discharge diagnosis, and if it's in the ED, some clinical impression. But I've mixed those together. What ICD-10 code that pulls out of there. So whichever one, discharge diagnosis at the moment, unless there's no discharge diagnosis, and then we're using admit diagnosis to get an ICD-10 code idea. The subclass of drug that was administered. And then this is the stuff that Dr. Lasso was talking about, our aware class. So is it watch, is it access, is it reserve? Some of these don't fall into a nice category that will match us up with the aware class. So we don't have a category we can fit those into. So there's a little bit of fuzziness there in that data, which we'll look at in a second. And then how the drug was administered, IV, intramuscular, oral, respiratory. And then this is just a number that's the total. By and large, this is one because we're getting one kind of drug administered at once. Different modalities for getting it into the body, and then we can eventually do something with that, which is why we're hanging on to it. So to Maria's point, this is a lot of data. This goes hundreds of thousands, 78,000 rows now. We're getting close to 100,000. We're not quite there yet, but so this is not useful very much for any normal person to look at. No one wants to stare at 78,000 rows of data with a whole bunch of stuff going on and figure out what's going on. So this is what we ended up with as our outcome. So this is the dashboard that we have taken a long time to develop. So I'll walk you through what's going on here, and then I can show you some examples of what's happening. So the top left box, this is whichever thing you've picked, total days of therapy. So at the moment we're looking at all units. You can see this is normalized per 100,000 days. We can turn that on and off. Although I don't think there's any reason to ever turn it off, normalized per 1,000 days. So it's looking at the unit at the moment. You can also flip it to look at services. I'm just gonna click on a service down here. Let's see, where's general surgery? Yes, there we go, general surgery. So if you flip it to service, this will flip to a service. If you flip it back to unit, you can pick a unit and it will show you data for that. And you can see all these graphs changing. So at the moment, I'll flip it to 4 East because that one's there. So the moment we're looking at 4 East right there, this is their overall days of therapy going back to 2018 average per month. And then this darker dotted line in the middle is the average. The outside control limits are the 95th percentile confidence interval where we're going to fall. Actually, that's three standard deviations. I apologize. So this is overall days of therapy. Then next to this is for whichever subclass you've picked, the days of therapy on whichever area you've picked. So at the moment you can see we're looking at third generation cephalosporin on 4 East, normalized per 100,000 patient days, again, going back to 2018. And we'll play with this in a second. So then below that, we have for the subclass you've picked, and for whichever time period you're picking. So you can see we're looking at now still days of therapy for third generation cephalosporins. This is just in 2021, so the data we have for 2021, and a ranking for either the service location or the unit that you're in. So 4 East is using the second most amount of cephalosporin third generations right now in 2021. And then the last way that we're going to look at that, or the last way we're going to look at this at the moment is for 4 East. Here's the top. I think that's 15 subclasses of drugs that are being used on 4 East, and where does the one that you picked fall in that list? So at the moment, they're using 4 East is using the fourth cephalosporin third generation is being used fourth most often with 120 days of days of therapy. And again, that dotted line on both of these is the average number for these graphs. When we get down here to the bottom, this is where we're starting. This is still a work in progress. We're still trying to figure this out. This lets us take a look at for over time for some sub-special classifications of the ICD-10 codes. What are our days of therapy look like? So at the moment it's on all codes, and if we put this on all units, these graphs look basically the same. There's some fuzziness there from timing, but if we pick like UTIs, you can see what's going on there. So this is a subclass of the ICD-10 codes based on to come up with a diagnosis from the data to look at what's happening for that diagnosis in days of therapy going back to 2018. And then finally, we have this idea that we're trying to look at and understand, is our ratio of access to access and watch, we're ignoring reserve drugs here, going up. So we would like to see this go up, as Dr. Leseau was mentioning, we would like to see more access drugs, less watch drugs. So over time, we're trying to understand what's happening with our ratio of access to access plus watch. Okay, is everybody clear on all those things? Did anybody have any questions about what any of these graphs are showing us? Okay, hearing none, I'm going to give you a couple of examples of how we can use this thing. So, so we're on unit. We're going to look at the neonatology, so the NICU and glycopeptide use. So, so this is as I'll walk you through it again. This is neonatology's use days of therapy overall. You can see that this has dropped a lot in the 2021. So they were pretty stable for a while. Their confidence intervals were, narrower in 2019, a little bit wider in 2020. Something has changed, I would say, from my eye in their variability in use in 2021. And then if we look at glycopeptide, this has been decreasing pretty consistently year over year, and the confidence intervals are getting narrower. So both our usage is going down and our variability of use is going down. So bear in mind, these are all averages at the month. So this is less variability or less, variability across the month. So seeing this go down is saying that we are using less. And then I will flip this to third generation cephalosporin, still for the NICU. So something, so the third generation cephalosporin, this has been pretty stable. It was down in 2019, up in 2020. It looks like it might be recovering to the 2019 values again for 2021. Still early in the year to be claiming that. And then I think this is the one that does this. Yeah. So you can see if we go down here, how are we going to use this? So, at the moment, you can see where third generation cephalosporin falls for NICU, both in their usage and where they are in ranking. This is 2018 data. There's 2019 data that was down a lot. There's the 2020 data. It's back up again. 2021, we're back down. There's one of these examples, and I can't remember which one, where we actually can see it stepping down. That our usage, is both, the overall usage isn't necessarily getting a lot less, but we're using it less compared to other drugs. So that's a location. And I said location because there is, if you look in this list here, if I scroll down to, where is it here? There is critical care, complex care as a service. And I think there's no, there's not.
Maybe
so
general pediatrics. Yeah.
Yeah. So there's, I'm just going to look at here, I'm gonna go to pediatric medicine here. So there's a bit of fuzziness in terms of if you're looking at a service or if you're looking at a unit. So I think that the data, the way it's built, if you have a location like the PICU or the NICU or those two are really the best ones. Those are going to be more accurate than using the service because we're not off servicing NICU patients to other places in the hospital. We're not really servicing PICU patients off other places in the hospital. So those are sort of self-contained. And then when we get to something like pediatric medicine, those kids can, they are mostly on 4Es, 5Es, but they could sort of be all over the place. So then we want to flip this to service to be able to look at pediatric medicine. And then, so we're still on third generation cephalosporins. Again, stepping down, and our confidence intervals are getting narrower. So to my eye is the stats, this is going in the right direction. And then is this the one? I'm just going to flip through here, 799. No, okay. I can't find the one that was, we had a great example of watching our usage go down year over year, but I can't remember which one it is right now. And then I will flip to macrolides. Again, great, downward trend. And then there was one that we wanted to show that was not heading in the right direction. And I think it was penicillin. No, that one's. Okay, let's flip back to go with the PICU and unit and glycopeptides. Okay, so this is the PICU and glycopeptide, and I would say this one we can't really say anything's changed. The confidentials are a little bit narrower, but but this the average is pretty stable. Anyway, I could keep flipping around and clicking on things all day long. Does anybody have anything they would like to see as a combination of sources of of data? Or I mean, the point of this is that we're trying to take that 78,000 rows of data and collapse this down to something that is actually usable and is sort of choose your own adventure in terms of how you would like to slice the data to be able to self-service and play with and see what's going on with a certain area and subclass and combination.
Anybody can ask for their unit to be looked at.
If you're willing.
If you're willing.
Nicole, this is Waleed. Do you have ED there?
There is ED in here. And there is ED in, is emerge in this one? Yeah. So there is emerge in this in service as well. So this is where the funniness starts to happen, because there's, I mean, I think that the emerge data here is better in terms of location. I guess maybe it's because they're self-contained as well. If you look at the emergency service, there's some funniness in the data. This probably partially related to this thing is built in Excel and it has some back end funniness going on. But yes, there is emergency in here. Do you have a subclass you'd like to see?
I'm going to find you.
Let's see cephalosporin.
Third generation or first generation?
Yeah.
Third? Okay.
Yeah.
Third, there we go. So there's third generation cephalosporin in the administered in the ED.
Who has septambular, I think. No.
So again, this looks, to my eye, going down, confidence interval getting narrower there. So our variability is getting less in terms of our use.
Ted, I just did my last French class until September.
Great. Yeah.
So,
So I think that I think Matthew, there's that system Power BI that will probably, can you just?
Yes. So I said, so there's some problems with this thing being built in Excel. I'll show you what sometimes happens. If you click on something, it starts to freak out and tells you there's a problem because it's built in Excel and it has some Excel quirks in the background. So if you click just one subclass, it will have a problem, and then we can just, it recovers again if you just click a couple more times. So this is, and to Maria's point, this because it's built with this, this ugly data set as the back end, takes quite a bit of work to populate. So Maria has to pull data that takes a long time to run because it's pulling a lot of rows of data. And then I have to put it into this Excel ugliness and then fix up a bunch of stuff that's hidden away that no one needs to see to make the graphs work the way that they work. There's the Power BI, the reporting team with Casey Parker has this new system that they're bringing into place called Power BI, which really is designed to do stuff like this, let you drill down in data and let you self-serve and pick and play with, I'd like to see this and this and this together, and it will chug away and produce that as a result. They currently have some issues in terms of the licensing of Power BI to have enough people that we can give it to everybody in the hospital and we can all access it at once, as well as having someone who can build this as the back end hired. So they're in the process of hiring that person. We have this in the list of projects that should hopefully be one of the first things that person does. But it will take a little bit of time to convert over to something that's in Power BI that is both robust enough to be distributable to everybody in the hospital, as well as working the way that we'd like it to work. So we're trying to, that is in the pipeline. It's just going to take us a little bit of time to get there.
Great. Okay, so we're getting towards the end. I just want to leave a few little minutes for question, but I just want to Matthew, is it okay if I share my screen?
Yeah, for sure. I'll stop. And I was just going to say before you flip your screen on, this is currently not saved in a very user-friendly location, but that's only because it doesn't have a home somewhere else. It's easily findable for a home somewhere else. And then people can play with it with the caveat that it is not ocean going, and it will sometimes give you some of that stuff that looks like it's crashing. And just if that happens and you're playing with it, just click a couple more times somewhere else and then go back to the one you were trying to do, and it usually recovers.
Okay, I guess I should say, do you guys see my screen? Do you see my screen?
Yes.
Yes.
Okay, all right, so I'm just going to we'll just have time for questions, but my take home messages basically is I think there's a strong association between adverse events and durations of therapy, and that should impact really the way we practice ID and do some very significant ID research. And I just want to thank all those people, the stakeholders. That I think the ASP program at CHEO is good, and particularly thanking Maria and Matthew, who really worked very, very hard at this dashboard. You can see it's very complicated. And I think a dashboard can be used to monitor changes and use of antimicrobials over time. And we can look at targeted interventions and aiming to at optimizing our use. I think this will be a very useful tool for individuals and groups to look at on their own to help them with antimicrobials. So here's just the last slide. Thanks for listening, and we certainly can answer any questions you have.
Great, thank you very much, Dr. Lusseau, for amazing antimicrobial stewardship, tour de force, and Matthew and Maria for allowing us to peek in the box to see the tremendous amount of work that's gone into this clear and important metric and dashboard. So we have a few minutes, and happy to take some questions, pose some questions to the team. So I see that Sandy C had posed a question about, it's nice to see these trends. Will we be using this to aim for specific goals for usage and or duration of use?
Yeah, I think this is really a gold mine, really, for people to do their own look at their antimicrobials, and for people if they have projects in the emergency department, for example, or other units where they want to look at the effects of interventions. So I think as soon as we have, hopefully the Power BI, but you could even do it now if you wanted. We have to just, there's a few little tweaks I think that Maria and Matt would like to do, but the eventual goal is to have people have access to this dashboard for their own units. Yes.
You're muted, Chuck.
Other questions? Dr. Batt is asking about how are you shifting your central line in the graphs? Is this statistical or using SPC rules for run control charts?
Yep. So I'm just running based on the year. So we can look year over year. It's really, I mean, it's not actually a statistical analysis to determine if it's moved. It's time based, so that we can look and see what's going on year over year. We could do much more, in-depth stuff if we really wanted to. We were just trying to get an idea of what the time, the run chart looks like. Yeah, and then the control limits again are based on that on the whole year. The three standard deviations. Excuse my tongue. But yeah, it's not actually full on statistical analysis to determine if the center line has shifted or not, just based on the time.
Thank you. I'll just pose a quick question about whether there's any intent or plans of integrating safety or adverse events into this dashboard as well. To give the whole picture, as you previously presented, that there's some literature associated with the whole picture.
Sure, that would be a great idea if people reported consistently, obviously, to the safety reporting system. So we probably have to have a bit of a goal as to promote safety of antimicrobials, and then we could maybe have a line or have a separate graph. So I think that's a really, really good idea, and it certainly would incorporate both the good and the bad of antimicrobials. Yeah, good idea.
Thanks. And I see, maybe we'll just take this as the last question. It's about I believe it's about the Spectrum app. And I'll let everybody know that just like this dashboard that's being created, there's a massive amount of work being done by Dr. Saux and her team in the back end, updating all the time with pharmacy, the Spectrum app, which is a huge resource for the CHEO community and abroad. So the question is, when will this app be updated and shared?
Yes, well, Andrew and I really are working on it. We're hoping to get this organized by the end of June. But it just like Matthew said, there's probably, there's about, I think, 10,000 pieces of information in there. And when we always have to double check, verify, have the pharmacist verify. So we're hoping to do this by the end of June, and hopefully people will enjoy the new look. Yeah, and the updated guidelines.
Excellent. So please join me in thanking Dr. Saux, Matt, and Maria again for an amazing presentation in this amazing area that you're really leading the field. Thank you very much.
Thanks, everybody. Bye.